Hello, everyone, and welcome to the Flint Community Webinar, your community resource. Happy 2026. I hope everyone is having a decent start to their new year. We're so excited to welcome you to the wealth of expertise we have today. We have such a diverse level of expertise that we're going to be talking with today. We've got our usuals, our OGs, we've got Doc G and Nurse T, but we've got some special celebrity people here too. We've got Dr. Shergill, who is wonderfully like family to all of us, really, because she is the wonderful Dr. Esch's mom. And so on the webinar, we have always talked about how much the community is so important to us, and extending our community and having the opportunity to extend our community to literal family is so awesome. We also have Dr. Lyroff, who's going to talk to us a little bit about what we teased about at the end of the year. So, at the end of 2025, we were seeing some things in the news about fungal infections, and she helped bust a little bit of that myth. But she's going to go into more details as we promised at the end of 2025. And then to round out our family session with community, we've got our community doc who's from Flint and just a wonderful wealth of knowledge and expertise. We've got Dr. Harris to talk to us about chronic conditions. So we are full of wonderful expertise today. Really excited to get into things. I'll let Dr. Lyra kick us off.
Unmute myself. All right. Thank you guys so much for the opportunity to talk to you all again. I apologize. I'm a little congested today, but I'm excited to share some information with you. As always, I really want these sessions to be interactive. So if you have any questions, feel free to put them in the question box. I want what I say to be relevant. And without further ado, let me just get my slides up. Okay. Can you guys all see them okay? Okay, good. Okay.
Yes,
so today, yep. So today we are going to talk about Candida auris. There has been a lot of kind of catastrophic, apocalyptic headlines in the news about this. You may have seen these specific to Michigan. I also saw a headline that was national the other day. And we're going to be really careful about the terms that we use here. And so first, we're going to just talk about Candida auris. So Candida auris is a type of yeast, which is a type of fungus that is part of a larger family of fungus called Candida that are present on all of the surfaces in our body. It's very, very common. You know, babies get diaper rash, women get yeast infections, people on antibiotics can get thrush. These are all overgrowths of Candida. And it's not usually something that causes a problem unless there is somebody who is very immunocompromised or has a lot of like invasive lines or chronic underlying conditions. Candida auris specifically has become an emerging concern. It is not new in the sense that it's been around for many years, primarily in Southeast and Eastern Asia. And this is a yeast, though, that has kind of been spreading westward over the last several years. It is present on skin, and like all Candida can cause invasive infections, but only if very specific situations arise. Candida auris can spread in healthcare facilities. It can remain on hands and equipment. It can persist on surfaces. It can be hard to identify without specialized lab methods, which was a bigger issue when it first started to be found in the United States. But we've gotten better and better with our lab services at addressing that. Now, it's really important when we talk about Candida auris to differentiate between colonization, in which the Candida is just found on swabs, and infection, in which case it's causing invasive disease, like it's found in blood cultures in patients that are critically ill or in other contexts. But these words are very important when we talk about Candida, because just having the yeast present doesn't mean that it's causing invasive disease. And so when we talk about Candida and when you read these numbers, it's going to be really important to differentiate between colonization and infection, because they're two very different things. So Candida, like I said, is part of this family of fungus, and there are many that have always been around. So that's one of the things I want to really emphasize today, that it's not like this is a new thing that we have never seen before. Candida is primarily a colonizing organism, which is to say it doesn't usually cause deep invasive disease. But one of the big differences between Candida auris and other Candida species is that Candida auris is not something that's usually just naturally found on people. It's something that is found on people if they've been in contact with other facilities or individuals that have been colonized with it. So it's newer in that regard. And it is broadly treatable with antifungals. About 97% of Candida auris species are susceptible to a class of antifungals called echinocandins, but it is a little bit harder to treat than like Candida albicans, which is the most common Candida species, which is commonly treated with an oral antifungal. So I want to allay any concerns. It is treatable. It's just the treatment is a little bit more complicated when it does become an invasive infection. The other difference between Candida auris and other Candida species is that it can persist on skin and surfaces more readily than other Candida species, which is why it has this broader concern for going from one facility to another when patients who are colonized go from one facility to another. So like we talked about, most Candida species arise from your own colonization. So like Candida albicans, Candida glabrata, very common in the GI tract, in your mouth, in your vaginal flora. Candida auris is more likely to just be a skin colonizer in people that have been exposed to it. It's not usually naturally found coming from your own body. And so that's why, as it's being investigated by public health officials, it's seen as something that's exogenous, external to your body. It's something that is being tracked to try to see how it's spreading and which facilities are more likely to have it. So this distinction between colonization can be really complicated. So if people have any questions about that, I'd really like to hear them so that I can better answer it. I'm trying my best to explain it, but I understand sometimes some questions were made. So this chart just shows some of the differences between most Candida subspecies and Candida auris. So both of them very commonly colonizers. Candida auris more likely to have azole resistance, and it has had some documented kind of candida resistance, which is usually the next line. But again, about 97+% of Candida auris species are treatable by this very common antifungal. And so there is more person-to-person spread with Candida auris than with other Candida species resistance. And when we say outbreaks, that's just to say that we're tracking who has it with swabs, but again, necessarily causing it headlines. That it does display a little bit more drug resistance than some of the other Candida species, but at this point is both treatable. It can't one colonist, one person long periods of time. So is what we call yeast is found in blood culture or
Dr. Lyra, you're
necessarily
breaking up
causing it to
just a little bit. It might, I don't know if maybe for bandwidth, if we
okay.
pause your video for a second and see if that helps.
Okay. I'm sorry. What's that? I'm gonna
No apology.
is that is
My internet in the hospital is terrible. Did we lose?
Think we have lost her completely.
Oh no, we were learning so much. Okay, no worries. As we wait for Dr. Lyra Roth, who's returned. All right. Can you hear us, Dr. Lyra?
Yep, I can hear you.
Okay, I actually think it sounds like the connection is fine. I see your slides.
Okay, That's all that matters. The slides are much more important than seeing me. So I just want to also emphasize that most patients who become sick with Candida auris were already very sick. We're not talking about this causing disease in young, healthy people. We're talking about this causing invasive disease in patients that have lived in nursing homes for long periods of time, have multiple, lines, maybe a a PEG tube on a ventilator, those types of very medically complex patients. It's not causing invasive disease in a 25-year-old who comes in off the street. So I want, that's a very important distinction to make here. So some of these invasive catheters that are more likely to increase risk of infection include breathing tubes, feeding tubes, venous catheters, urinary catheters, and people who do not have these risk factors generally do not carry Candida auris and do not get sick from it. So that's the biggest, if you take one thing away from this, I want you to understand that. So Candida auris was first identified in Japan in 2009, and 2013 to 2015, the first US cases were detected. And when we say cases, again, we're talking about just it being present on people's skin. From the late 2010s to the present, there has been rapid spread of finding this yeast on skin and on surfaces in healthcare facilities worldwide. When we talk about increase in cases, a lot of these cases, again, are screening cases. Whenever somebody does get sick with this, then we have to go back and we start swabbing any person who shared a room with them, any facility they've been in. There's widespread screening. And if people are positive, these become identified as cases, but they're not necessarily in cases of invasive disease. So the COVID-19 pandemic was a factor that contributed to accelerated spread as more people were in healthcare facilities and at a certain period of time, more people were on vents and things like that. So there's wider spread. So as you can see, there have been 4,514 clinical cases in the US in 2023. The statistics just came out recently for 2025, and I think it was around 7,000 cases. Again, clinical cases, very different when we talk about colonization versus infection. So you can see that in Michigan, this was the most recent data I could find through mid-December, there have been 2,256 total cases, but of those, 1,688 were screening cases, which means it was found on a person, not causing disease. 568 cases were clinical cases in which there was invasive disease, but again, nearly universally, all of these patients were patients that were already very, very medically complicated and very sick. So you don't have to worry about this being something that you get just walking down the street. So in Michigan, only about 11% of colonized individuals go on to develop a positive clinical case. And again, even patients that are colonized are more likely to be those that are sharing rooms with these medically complex patients, so are also likely to be medically complex themselves. So when we talk about like where are these being detected, 64% of these screening cases are in acute care hospitals, 20% are in LTACs, which stands for long-term care facilities, and vent-capable long-term care facilities, about 11%. So you could see that there are cases that have been found pretty much throughout the more counties. These cases kind of when we talk about the clinical cases, like where the invasive disease is coming from, most of them are either in urine, blood, or respiratory, which is to say urinary tract infections considered, I guess, like a pneumonia, although I would be very hesitant to call a candida a pneumonia. And when we look at susceptibility, you can see that most of the isolates in Michigan are susceptible to something. 99.8% are susceptible to something, right? At least amphotericin. 98 to 97% are susceptible to a kind of candids. And so, we do have treatment options. This isn't a worst case scenario. And so when we talk about, what this means for Genesee County and Flint, the most important thing is just be careful and practical. If you are seeing a family member or somebody who's in a facility where there are contact precautions, respect those contact precautions. But outside of that, I don't think people have to worry about this. I think this is something that healthcare providers need to be aware of, but everybody on the street, I don't think you have to be worried about getting sick. So local facilities should prioritize screening patients if they're high risk from facilities with known transmission, maintain contact precautions and strict hand hygiene if a patient is known to be colonized, and practice aggressive environmental cleaning and coordination with the Michigan Department of Health when cases of colonization or infection are identified. So that's pretty much all I have to say. I hope I allayed some fears, but I know there may still be some questions that remain because colonization versus infection can be complicated.
This was wonderful. Thank you so much for this comprehensive overview. What I appreciated is as we talk to community, people want to understand the background and they also want to understand what they should be worried about. And I appreciate the extent to which you clarified kind of that this is probably not something that we as healthy people walking around need to worry about. I do want to ask because we have some wonderful people representing our older population. I see Yasika. I saw a couple of people. I see Doc G. I see Nurse T. Right. And so as we think about our more at risk populations, what are the symptoms that people should be kind of thinking about might be at risk for that not colonized, but actually might be, disease that we need to worry about or something that needs to be treated, even in there people who might be in hospital settings where they're sicker?
Yeah, absolutely. I think so. This is generally found when there is already an ongoing investigation for something. So it's not that people come in and you don't know what's wrong. It's somebody comes in, they're septic, right? They have a high fever, low blood pressure. And so you start taking cultures from everywhere. You take blood cultures, you take mucus cultures, you take urine cultures, and that's where it's being found. So when the clinical manifestations are related to the site of infection, but what I would say is that you don't have to worry about any other specific symptoms in the community. This is something that the healthcare team should be able to identify as they're working up sources of infection for a patient who comes in very, very sick. Did you hear me? Okay, I guess the other, I see there's also a question on ways. Did you hear me there or did I cut out again?
I think I cut out, but I think we're all having,
gotcha.
There's an internet gremlin somewhere just attacking our internet.
Yes, yeah. No, I was also going to say, I see there's another question about ways to prevent. And I would say, as far as I'm just really practicing good hand hygiene. The truth is, and I'm trying to here, but that if this is present in a healthcare facility, you do heavy cleaning, you put contact precautions, but it's also something that is spreading despite our best efforts. So I think this is going to be something that healthcare facilities just get more comfortable with. The way MRSA was something that we were all ringing alarm bells with, and now it's something that we have a lot of comfort just identifying and treating. Not to say it's not always an issue, but sometimes new pathogens become more prevalent, and we as healthcare providers just have to get better at doing our end. I don't always think it's like the community's responsibility in these cases when something is just so readily a colonizer.
That's meta, right? Like, I don't think it's the community responsibility whenever there's colonization involved. Okay, thank you so much. I think that's really, really important information for people to hear. Appreciate your expertise always. Thank you, Dr. Lyroff. I am going to transition us just a little bit. We're going to give it to Dr. Harris to talk a little bit about chronic conditions and things that we need to consider. Happy New Year, Dr. Harris. It's good to see you.
Thanks. Happy New Year to you too. Thank you. Thank you. So I don't have any slides. I just kind of have a list of things that I want to talk about. So Today, I was asked to talk about kind of how different chronic issues can increase your risk of like wounds and how that plays into the wound healing process. And so I kind of broke this down into four areas that I wanted to kind of more highlight in general. So metabolic disorders, vascular issues, infections, and then just trauma. Kind of starting with the metabolic disorders, mainly because I think these are the chronic issues that people don't connect to potentially having higher risk kind of wound issues and wound healing issues. And so the one I mainly want to highlight is diabetes. So as much as we talk about diabetes being a problem associated with high blood sugar and it causing kidney problems, potentially it causing cardiovascular problems or blood vessel and heart problems, it potentially increasing your risk of eye problems as far as your like vision and your eye health. Diabetes itself also increases your risk of having different infections, but also increases your risk of having poor wound healing ability. And this is mainly because diabetes, as much as we talk about the blood sugar aspect, it impacts your blood vessels on a regular basis, especially your small blood vessels, which is why it can impact your eye health because your eyes have very small blood vessels. If you have damage to those blood vessels, then you can have eye damage related to your diabetes. So in that same context, diabetes can impact your microvascular uh, I guess, microvascular disease, microvascular blood vessels in general, and that can decrease the oxygen going to those different blood vessels. And so if you have a wound that's trying to heal, if you don't have oxygen going to that wound on a regular basis, then you're going to have problems with your wound healing overall. The other piece that diabetes is often related to is neuropathy. So numbness, nerve injury, and how that plays into your wound aspect is if you don't have very good feeling in your feet, if you don't have very good feeling in your hands, and you have some injury there that you aren't able to tell, especially in your feet. Like a lot of people don't look at the bottom of their feet often, which is why we do foot checks with diabetics. If you have an unrecognized injury and that injury just keeps festering, goes untreated, then you're going to have a lingering wound that will then have to be treated farther down the line. Maybe it's not recognized for multiple months versus it being recognized that first week. And in that same context with diabetes, when you have a wound and you have all these vascular issues and you're diabetic, then you have trouble having that wound heal. That wound that you've already, a patient's already been delayed with having it checked out. Now you have poor wound healing ability because of just the diabetes and your vascular health and your impaired immune system overall. Outside of that diabetes, people can also have pre-diabetes. So you might not have a full-on diabetic diagnosis, but having pre-diabetes still has high blood sugar in your blood system, which can also cause other vascular issues. You can have steroid-induced diabetes, not diabetes, steroid-induced high blood sugar or stress related high blood sugar from the things that you're eating, the things that you're doing. So all these things can play a role into like how your blood vessels are delivering oxygen, delivering nutrients, but also how your body is addressing the different wounds. As well as with high blood sugar, you also have an increased risk of an infection in general. And so one of the things that we get concerned about when people are diabetic and have these high blood sugar levels kind of running through their system is diabetes just makes you more prone to having more complications with a lot of different medical problems because your immune system is not as strong. And so when your immune system is not as strong, then you have an increased risk of more severe infections because you don't have the not the willpower, but you don't have the components in your body to fight off the infection as well. And so when it comes specifically to wounds, if you aren't able to fight off that infection that well, then that wound potentially could be a wound that becomes more infectious or a wound that just doesn't heal as well. And I say that in the context that not all wounds have infections. Some wounds are just wounds where you have a lesion in your skin. There's multiple layers of your skin that's kind of exposed. There might be some tissue damage. There might be some leaking or fluid kind of coming out. all because a wound doesn't look that great doesn't necessarily mean it's an infection. But one of the things that we're trying to keep from happening with wounds is that the infection occurs. And so when you have diabetes, you have increased risk of infection because of your impaired immune system, and that could play a role into how your wound is healing, and oftentimes it causes your wound to heal slower. And so there's often a lot of people who might be in the hospital who might have uncontrolled diabetes, and the surgeons are not as excited to do a surgery on them because they know as soon as they do the surgery, do the operation, they're at increased risk of an infection because of diabetes, but also at increased risk of slow wound healing. The other piece, as far as a chronic issue that I want to talk about, is any type of vascular disease. And so you have arteries and veins that help run blood and nutrients to and from different organs and different parts of your body. And so if you have any problem with the blood flow going to a certain space, or any damage as far as how your arteries and veins are functioning, that can also cause problems with wound healing, because you can imagine if there's a cutoff somewhere where you aren't getting oxygen or you aren't getting nutrients to the right place, then that's what the wound healing process is utilizing to close that wound, to keep it clean, to keep it healthy. They're utilizing the nutrients and oxygen that's coming from these different blood vessels. So if you have leg swelling from venous insufficiency, where you aren't able to pump all the fluid back into your vascular system very well, and that swelling is just sitting there, then if you have a wound in that area, because the fluid is not moving on a regular basis, you're going to keep that wound a little bit more moist, which is not ideal, but also potentially a little bit more kind of stretched out and stressed, because your skin is being pulled because of the extra fluid. If you have a place that doesn't have very good blood supply in general, it's not going to be able to have the oxygen. It's not going to be able to keep that skin and that tissue alive as well. And so if you have a wound, you don't want your skin to be damaged and tissue to be damaged enough where it's hard to keep it alive, because then that makes it difficult for that wound to heal. And that's kind of where we get into the idea of discussing kind of amputations related to a wound if you aren't able to keep your blood flow alive in those spaces. And so we don't want vascular issues when it comes to arteries and veins to compromise your wound healing, but we have to address the bigger picture when it comes to your primary care or your hospital care, because things like heart disease, as far as heart failure, can cause people to have a lot of fluid in their legs. Kidney disease and liver disease can cause people to have a lot of swelling, and so we don't want these problems to manifest to extreme difficulty when it comes to how your wounds are healing. So we want these chronic issues to be as well managed as possible. So if you do get a wound for whatever reason, you're able to kind of get it controlled better because these chronic issues aren't impacting it. So
Dr.
those
Harris,
are
can
kind
I ask you a question related to that? As you talk about these chronic conditions, and I apologize for interrupting, but you were so tangential to it that I wondered, and I saw some hints at this in the chat. When we think about chronic disease and we think about needing good blood supply to all of these areas, is there a link between chronic illness and some of the cancers that we see in community, or some preventative things that we might need to consider related to chronic disease, and how we might need to be thoughtful about decreasing our chronic disease burden to decrease the potential risk of cancers down the line? Is there any link there that we need to be thinking about related to letting how people manage chronic disease or prevent chronic disease that might also be linked to how people improve or decrease their risk of cancers?
So I didn't look into the cancer stuff specifically, but I will say with chronic diseases, at base, chronic diseases can cause stress and inflammation in your body. And so when it comes to cancer, if you have increased stress or increased inflammation in your body, you are making yourself a little bit more prone to different cancers either manifesting, or different cancers having a more difficult time being treated in general. When it comes to chronic diseases that are impacting certain organs and stuff, then you're getting into how the tissue in that space is getting turned over, how the tissue in that space is getting maintained. And if you have enough abnormalities in a certain organ, then that's where you get your increased risk of cancer. Because our body's constantly turning over things, our body's constantly changing. And so you can think of it as if you have enough errors happening, eventually, if those errors keep happening for years and years and years because of a chronic disease, because of inflammation, because of some random exposure, then you're increasing your risk of abnormal tissue that the body is no longer able to kick out, no longer able to address. And then if you have enough abnormal tissue, then that's where some cancers can start to develop. And that's why we do biopsies. That's why we kind of check different tissues, because cancer is very unique to every person. And we don't know why you have that abnormality, why you have that cancerous tissue. And that's why we have to get more information when that comes. But that's how I will kind of connect the chronic disease aspect as far as inflammation and stress, but also that constant turnover of that tissue is not good for the body, because now you're having a lot more errors, and errors start to increase your risk of different cancers.
Thank you so much for touching on that. That was one of the things that we heard from community in terms of how does the rate or the burden of chronic disease relate to the potential for cancer risk. And I appreciated so much you were kind of dabbling in this idea of chronic stress, and certainly that inflammation, those chronic errors definitely are things that we need to be thoughtful about. So I didn't mean to interrupt. I want you to continue on. Thank you so much.
Oh, you're good. And so the last things I do want to point out is the like active like trauma and damage we have to skin problems. So in primary care, we have a lot of people who come in for just general like skin infections, superficial infections that we're trying to treat in general. And sometimes those skin infections are below the surface. We can see how they show up in rashes. We can see how they show up in pain and warmth and discomfort. But sometimes those skin infections can surface as far as like if you think of your skin being kind of like a volcano where it just kind of erupts, and that's where infections become wounds that we have to treat. We have to both treat the infection that's happening, the bacteria that's present, but we also have to treat the damage that's happened to the skin that is no longer under the surface, but is also superficial and able to see through the common eye. There are some different medical problems that are more likely to have skin disorders than others, but we are always kind of aware of the infections, the chronic diseases, the autoimmune diseases that might cause someone to have an increased risk of infection and inflammation that may surface into a wound. And then the other piece, which is probably the most common thing that people think about wounds, is just trauma. So you have a scratch, you have an injury, you get into a car accident, you fall on something. Those are more obvious wounds that can occur. Sometimes people are able to see them and feel them. Sometimes people don't know if they're present, whether they're on your back or if they're on the bottom of your foot, or you have some nerve pain somewhere to where you're not able to tell, or numbness somewhere that you're not able to tell that there's an injury there. But we want to be well aware of when these traumas happen to the skin, so that way we're able to treat it, help it out, make sure the skin's healing as much as possible. Because what we don't want, which I said earlier, not all wounds are infectious, but we want all wounds to stay uninfectious as possible, because having an infection causes even deeper problem. And when you have a skin infection, it can also turn into a bone infection. It can turn into a systemic, like full body infection. And that's where people end up being in the hospital, because their thing that started out as like a quarter size infection on their arm spread into their bones, spread into their blood vessels, and now they're on IV antibiotics in the hospital because of a small, minor infection that wasn't treated fast enough, wasn't treated appropriately enough, and now they're really sick. So we want to treat all kind of wound injuries, all infection kind of risks as soon as possible, so that way they don't turn into something more serious.
This is amazing. I have, I'm a corny family doc. So I'm thinking like you bring an ID doc, a family doc, a wound care nurse practitioner doc, and you got Doc G, a nurse in the community, into a webinar. And this is what we get, which is just really, really outstanding. Thank you so much for sharing your expertise with us this new year. I'm going to pivot us a little bit to Dr. Shergill and the wonderful mama of Dr. Ash. I love getting to say that. And she's going to talk to us a little bit about the things that Dr. Harris talked to us about. We've got a bunch of questions in the chat for your expertise. So I know you've got a little bit of time for Q&A, but I also know you're going to cover a lot of this stuff. So please feel free, take it away with your slides. And we look forward to hearing your expertise.
Yeah.
Hello, my name is Hardev Shergill. I am a board certified family nurse practitioner and a board certified wound specialist. Regarding my education, I graduated from Oakland University with my Doctor of Nursing Practice in 2018. I have spent about 13 years as a family nurse practitioner and wound specialist, and over 25 years as a registered nurse. I have worked in outpatient clinics and post-acute rehab facilities and long-term care.
I am so sorry, Dr. Sugar. I should have introduced you because you have such phenomenal expertise that you deserve a round of applause and someone to introduce you. So thank you for telling us about all of your wonderful credentials and your background.
Well, thank you. So a disclaimer, I just want to make sure that the views and opinions in the presentation are from myself. Information I've compiled from various leading evidence-based wound care resources, and that will be presented in the reference section in the PowerPoint. The presentation is solely for the purpose of teaching and education and is not intended diagnosis or medical management of wound care. Objectives of this presentation include discussing and dispelling some common myths regarding wound care, to review basic wound care at home, and to recognize signs and symptoms of infection and or complications and when to seek medical attention. So let's review some of the myths that I have come across with my patients and my colleagues. We've also discussed them. So things like cleaning with alcohol. Well, it's good to clean with alcohol and good to clean with hydrogen peroxide. It's a good idea to let your pets, your dogs and cats, lick your wounds, or I really need to leave the wound to dry to air, or my wound needs to breathe, so I take the dressings off. I always use Neosporin or bacitracin or triple antibiotic on all wounds because they're infected, or I just need to make sure they heal. Well, doesn't it make sense? The more the wound is cleaned, the quicker it heals. So let's look at these myths individually. Alcohol. When you use alcohol, it tends to dry the skin and strip it of its natural protectants, natural oils that are produced by our skin. Alcohol will kill bacteria, even the healthy ones on our skin. And alcohol does not support the new cells that are forming in the wound bed to help it heal and close. Hydrogen peroxide has very similar effects. Neosporin and polysporin and triple antibiotic ointment, there is a high likelihood of developing a severe allergy. And this can occur even if you've used it multiple times before. Now, we all love our pets, and it's great when they lick us on our skin, as long as that skin is intact and not broken. Because the saliva in the animal has different bacterial colonies to our human skin. And so when they lick an open wound, there's actually bacteria that shouldn't belong in human skin sitting in there, and this can increase the risk of an infection. Other myths. I'm going to jump to the bottom of the slide so typically, wounds that are cleaned more frequently are cleaned for the purpose of removing bacteria for infected wounds. And the main goal is not healing, but to try to clean that wound bed in preparation for healing. So it's a good idea to clean it every day or every other if we are looking at healing and this is not an infected wound. What that does, the cleaning process, is to remove byproducts of the wound healing. Our wounds tend to have white blood cells that will eat up any debris and any products made through the wound healing process, and also some bacteria that build up. And it's more of a physical action when you clean it with a gauze dressing and you clean the open wound. So over-cleaning can damage new fragile cells that are trying to form to heal the wound. Over-cleaning can also delay healing by removing important healing cells or growth factors. And these are highly skilled cells, and they are trained to heal a wound. So if we clean the wound more often, then the body has to regenerate them more. That takes up energy and also time. So if it takes up more time, it delays wound healing.
Can I ask you a question about this? Can I ask you a question?
Yes.
So for Neosporin, you mentioned that it can cause a allergic reaction. Is there any literature to show that it could prevent infection as a help, or is it just completely not helpful and with the risk of just a wound not having an infection?
It's really not helpful to use. There are other alternatives, but for most wounds and for healthy patients population, it's really not going to help. The risk of having a severe allergic response is higher than it being helpful. And that's actually a board question in our wound certification is no to triple antibiotic or Neosporin. So we're still continuing with the myths. Let's leave it open to air. You know, it's got to breathe. We're worried that we're suffocating the wounds. They've got to breathe. Well, wounds don't need to breathe to get oxygen. Oxygen is carried to the wound bed, the wound area, through the blood. Now, if I move across, the healing is slower when the wound dries up. And this is partly because we mentioned the healing cells that are part of the healing process, these growth factors. Well, if I was to give you an example, let's look at red wings and when they play. If we gave them a field or an arena and we put sand in it, and we try to use that hockey puck, it's not going to move at all. It's a bit like the growth factors are trying to get to the goalpost where the wound bed is, but it's not going to make it. If we were to put the ice rink back on as an ice rink, that puck is going to glide straight into the goal, which is our open wound. If we were to flood it with water, again, the ice puck is not going to move. It's going to just be drowned in the water. It's a bit like that story of Goldilocks and the Three Bears. You've got something that's too soft, too hard, or just right. Yeah. So wound healing is optimized when we follow moist wound healing procedure. And that is the standard for today's evidence-based for moist wound healing. Not too wet, not too dry, just right. Open wounds do pose an increased risk of infection. An open wound on a leg, arm, on a knee, anywhere. We're touching at the surface table of a kitchen, then we're putting it on our hands or our knees, or it could be, or a dog could lick it. True. So they are at high risk of infection. So types of wounds that are manageable at home, an abrasion like a rug burn or a skimmed elbow or knee or a shallow cut or laceration. So cleaning wounds at home. Now, we typically use a clean technique for cleaning wounds, most wounds, and especially those at home. This means that we're not going to gown up and prepare for surgery. So we're not going to scrub for 15 minutes, put on gloves and the whole works. So at home, wound cleaning would include, I'm going to go down to actually hand hygiene. And this has been mentioned before. I can't emphasize the importance of hand hygiene. This is one of the most important factors to reduce the risk of contamination and infection. Hand hygiene includes hand washing with soap and water, and hand sanitizers are also considered as part of hand hygiene. So the other parts are, it is important to make sure that your surface is clean, and also that you have a clean towel or a chucks pad, something that you're going to put all your supplies that you're going to use for that wound cleaning process. Clean gloves, that means they come in a box, not individual sterilized packets. The supplies are going to come in a sterilized package that you open, your dressings and stuff.
Gauze.
And gauze dressings. Now, someone might ask, well, what about the big gauze loaf, the ones that don't come in individual packets? You can use that, but again, you have to follow strict hand hygiene rules. For example, if I took a dirty dressing off or a dressing off in my process of cleaning a wound, and I use those gloves to dip into the loaf, well, I'm contaminating it. So, however, if I was to prepare that gauze initially at the beginning and put it onto my clean surface, I can put away that loaf and use the 4x4 gauzes on that clean surface. So briefly, let's wash your hands before you start. Prepare the field. It's a bit like cooking. You know, you wash your hands, you prepare, you get everything out of the fridge, all your vegetables, all your stuff to prepare. And you do it on a clean chopping board too. So very similar for cleaning wounds. We're going to use non-sterile gloves. If for some reason you don't have them, at a pinch, you could open a new box of plastic, like Ziploc type bags. You could put your hands and use that as gloves if you had to makeshift. Again, importance of hand washing after you've completed the task. And then we're going to look further down in the other slides of what to look out for if wounds are infected or when to call the medical provider. I have a link here.
And we can share that link in the chat. So we'll make sure that gets shared with everyone.
Okay. So, okay, this is one link, and then there's another. So basically, you know, you've got everything prepared to go. You've got your bag to discard the dressing you're taking off. Hand washing. So it's important to rub your hands thoroughly, make sure the palms and the top of the hand, between the fingers, the fingernails are cleaned. Okay, so as I said, this is a nice, useful leaflet to help as a supplement for resource. I'm going to go back to the PowerPoint because I know that time is short now. All right, and okay. That's another one. So soap and water. So for wound cleansers, you can use soap and water. Good old soap and water. It could be plain soap or antibacterial. It doesn't matter. The most important thing is when you're cleaning a wound, it's a physical action of removing debris and any bacteria. Normal saline, well, that's the fluid that our bodies are made of with the salt and the water ratio. So wound cleansers. These are specifically for cleaning wounds, and they're prepared with preservatives and they're pH balanced to the skin. But as I said, all three of these are perfectly acceptable. Common types of dressings at home. You have a thick ABD pad. You've got the gauze loaf we were talking about. You've got dressings where there's a foam in the middle, and then on the outer aspects, you've got the bordered adhesive. Now, if a wound is a bit dry or it's not very moist, we do want to make it a little moist. To keep it moist, you can use Vaseline-based or gel-based dressings or a hydrocolloid. Hydrocolloids are occlusive, meaning they don't really let air in. But, you know, we talked about we don't need to open wounds to let them breathe because the oxygen is also carried in our blood to help that wound. Kerlix bandage is to secure wounds on legs and arms. Let's move to signs of infection. Signs of infection would include increased redness or darker skin tone around the wound area. And this you're looking at not just a quarter or a point to an eighth of an inch or a quarter of an inch, you're looking at an inch, 2 inches around that. That's growing. The redness is growing further out from the wound. It's very painful. There's swelling around it, maybe a foul odor, thick drainage or pus, or a wound that's to be addressed, deep cuts with open or ragged edges. So you may see more white-colored tissue. It may be yellow, maybe clear with you've gone into the fat layer or you've gone deeper. A fever, numbness around the wound, that would be a concern, or red streaks. And you can have wounds regarding sunburn, and this sunburn wounds would look red or darker in color than the baseline, be very painful, blister, and then they may peel. So the best way to treat them is to apply cool water, not ice or cold water, or take a cool shower. And then once that coolness, once the skin has cooled down, applying aloe vera or petrolatum just to keep the skin a little moisturized to heal it, moist wound healing, drinking plenty of water, taking some pain relief medication, and most importantly, don't pop the blisters. If the blisters do pop, cover them with a moist dressing. Your body will reabsorb. It'll dry out the blisters because that fluid will just go back.
I think don't pop the blisters is a good advice for anything. Anytime you get a blister.
Anytime, yeah. Because if you pop a blister, you've opened a wound. If you've opened a wound, you've increased the risk of infection.
Mhm.
And now, also, if you have a severe, deep damaged skin with yellow, leathery, black, or brown color, for any burn, you need to seek medical attention. The deeper layers down the fat, muscle, have been probably damaged. Or if you have an extensive burn on the body or in a sensitive area, that needs medical attention. Extensive meaning maybe it's your whole leg or half your leg or your all your arm. If it's your face or other areas, then I would get medical attention. So this picture with the blisters, that's a second degree burn. If the skin was red or darker colored but did not blister, it would be a first degree burn. And then your third degree burns are where you're going to have yellow or leathery skin. And I've tried to give some a representation of darker tone skin to show some blistering from a burn. Now, as the burn skin heals, you're going to see the top layer drying up and peeling, and that is to be expected. The other thing I was going to say was for prevention. First, so it's important to protect the skin by using broad spectrum sunblock, at least SPF 30 or higher. Protect your eyes with sunglasses and use hats and linen or loose clothing, cotton clothing, so that, you know, they'll feel light and you're not going to build up that heat. You need to reapply sunblock every 1 to 2 hours, and more often if that area is more sweaty, because the sunblock's going to just come off.
And everyone should wear sunscreen.
Everyone
as long
should.
As they're older than 6 months.
So everyone should wear sunscreen. It was a false belief that the darker the skin, that you don't need sunblock. That is not true. Everybody's skin structure is the same, and we all burn. It's just, it's harder to see, but that doesn't mean to say the sun damage has not been done. You want to try to avoid peak hours between 10 a.m. and 4 p.m. to try and stay away out of the sun, if possible. The other thing is, it's very important to get to go to see a dermatologist for periodic sun checks of your skin for lesions or moles or any changes as a preventative measure. And that really sums it up.
You have given us so much wonderful expertise. I do have a few follow-up questions if that's okay.
Yeah, sure.
Awesome. Okay, so this is my personal favorite. Can you talk to us about putting toothpaste on burns and if you've heard that myth and why or why not that is something we should or should not be doing?
Um, I wouldn't put it on. I would just stick to I mean, if it may stick to your skin, then you're going to try to take it off. I think some of them have mint or menthol, so I don't know if that's why it's cooling. I'm not sure. I've heard of some cultures will put Vicks on a lot of stuff. In my Big Fat Greek Wedding, a movie, they used the Windex, the lady came out and said, oh, we healed them. Then we just put the Windex on when there was a cut.
Well, my family is Verner's and Vicks, so yes.
So Verner's is acidic because it's carbon. So I don't know. I don't really have an answer. And I know there was another question on.
There was a really good question about Vaseline and what the use of Vaseline could be and how we use that and if it's okay to use.
Vaseline is okay to use for superficial, partial, thick-skinned burns, rug burns and stuff. The thing is, if we allow the burn to sometimes form a crust, it's going to heal, but takes a longer time. So the Vaseline, you just need a small layer. You don't need thick layers of it. And it will just create that moist environment for moist wound healing.
What about like a small cut?
You can use it Aquaphor or Vaseline because what it will do is twofold. It'll help decrease the pain because the air is what's going to increase the nerve pain at the superficial level. And also it's going to protect, it's going to cover the wound and to form a physical barrier to reduce a risk of infection. And if you were to cover that with a Band-Aid or some kind of dressing, then you protected it and you've kept it warm. The other thing of changing dressings too soon is that you're decreasing body temperature. Wounds heal at optimal temperature, which is our body temperature. It's like if I was to put Grabaksha in a cold room, she's going to be tucked under a blanket and does not want to work. If I pump up the room to just the right temperature, I'll get more work out of her.
I don't know. Every time I run into Grabuck, she has an idea for more work. So I don't know if we could be
Maybe
in the Arctic.
It's not the right example. Maybe for me then.
I think it's a wonderful example. I'm just teasing. I had one other question. There are some really great questions and people love this presentation. I wonder briefly if you could make any connection between the idea of cancer and how that might cause delayed wound healing and if there's anything we should be thinking about there.
Cancer and cancer drugs, and there are other medications that delay wound healing. With cancer, you've got a decreased immune system, typically. Now, with a decreased immune system and a less than robust immune system, our immune system actually drives the wound healing process. You've got your white blood cells, you've got your monocytes, and some of them, they orchestrate wound healing because they're also triggering your growth factors, your platelet-derived growth factors. So it's a complex, and your interleukins are also part of wound healing. So when you've kind of compromised on that, you're going to compromise on wound healing.
Yeah. Thank you so much for this wonderful presentation. We've got 2 more minutes, and since we have you, I think this is a wonderful question for this wonderful duo that we have. So I'm thinking about kiddos who have itchy scabs or might have skinned their knee, and it also dovetails a little bit on what Doc G said in the chat that sometimes it's just really hard for people to not scratch or pick at their scabs. And I wonder if you have any last advice for people who have little ones or people who want to itch their scabs. What should they be doing?
I'm gonna let Grabaksha answer that one.
No worries.
Eczema is something that we see a lot, and eczema is known as like the itch before the rash. And so especially in our teeny tinies, I recommend covering it up. And you have to get creative sometimes. I've had kiddos who If they're young enough, we can just put them in socks. You know, you put the
Oh.
hydrocortisone in their Eucerin and you just put them in socks, you put them in gloves and they can't take them off. If they're a little bit older, you might have to get a little bit more creative. Meaning you might have to wrap a little bandage around it. You might even think of like doing a sock on the hand and then putting some sports tape around. Some kids respond better to goals, right? And so it's, you know, if you don't do this, and then the next step is this. So I think really it's about working together at developmentally appropriate ages. The younger ones just covering it up and, you know, leaving it there. The older ones working with them. How can we work this out? How can we think about this together? But yes, it is very hard. It's a huge struggle that we get into, and especially kiddos with eczema, increased risk for infection. So covering that up and not scratching is really important. And then there are medications that you can give overnight sometimes if it becomes too much of an issue.
Got it. Well, a wonderful shout out to the OG Dr. Shergill and a wonderful shout out to the new G, Dr. Esch. We super appreciate your expertise. Thank you to Dr. Lyroff. Thank you to Dr. Harris. What a wonderful way to bring us into the new year. We're leaving you with those continuing education credits, and please tune in next month.